Okay, I think next panelist, please.
Okay, so it's my turn. I'm Dr. Yang from Guangzhou, from Sun Yat-sen University Cancer Center, quite close to the hospital where Professor Wu work. So I quietly enjoy your presentation, Professor Wu. Thank you first, and it's quite impressive. And from your presentation, I remember one keyword: lorlatinib nowadays is the best. No matter whether you judge from the IC50 or the boundary rate or the PFS. Um, it's very important that you predict the when the in the Crohn study when the PFS rate reach 50, it could happen in the 11 years. So it's quite impressive, and I quite agree with you, partly, and I did notice that you speak a word that because the prognosis is quite well now. So in your opinion, you don't think now it's worthwhile to carry out uh, the clinical trial investigating the perioperative on neoadjuvant modality. Maybe in your opinion, because even when the patient with locally advanced disease, the prognosis is quite well, close to curative. So is that right? But because I'm a surgeon, so I still want to ask you one question. So nowadays, do you think it's worthwhile to carry out a clinical trial to investigate the effect of neoadjuvant lorlatinib versus a neoadjuvant ALK TKI, maybe the third generation, versus adjuvant. Because now for the lorlatinib, still no data regarding the adjuvant modality of third generation ALK TKI. So because we still don't have substantial evidence, although you have persuaded us lorlatinib is the best, but in the clinical world, we need guideline, we need evidence. So maybe in your clinical will you recommend to the patient undergoing radical resection with ALK mutation, we will recommend the lorlatinib for the patient for adjuvant therapy. So I'm quite interested.
Um, yes, I will. I will recommend lorlatinib. The problem is the trial has to be done by Pfizer because uh, so hopefully Pfizer will do it, but I'm not sure Pfizer is organizing a trial. I don't think 2 years of adjuvant ALK is enough. They do it because then it's easy to finish and it doesn't cost a lot of money for 2 years of alectinib. Neoadjuvant is also true too. I mean, the problem with all this trial is they're single arm phase 2 study. They all show some efficacy. You really have to do randomized phase 3 study. I mean, I would challenge Pfizer to go against alectinib in a head-to-head 2 years trial, but Pfizer is not going to do it because Pfizer has to do it globally, and the decision making is pretty slow. I do think once you get on, depending on the stage, you as you mentioned in the previous questions, the high risk features are variant free, high CEA in the pretreatment, potentially other site, maybe multiple lymph nodes involvement, given it's a neoadjuvant. I would definitely even start. In US, our surgeons are not that fast, so it may take 1 or 2 weeks before they can schedule surgery, authorization, schedule the operating room and all that, and then they travel. They only have 1 day operating. So a neoadjuvant lorlatinib. I mean, if I know somebody has ALK positive lung cancer, regardless of stage, whether they are going to undergo resection, I would start them with lorlatinib. I definitely would start them with adjuvant lorlatinib. I would not start them with alectinib. We don't have any data, but we also don't have data on stage 3 disease, unresectable stage 3 disease. What do we do there? That is the missing. So we have the adjuvant, ALINA, 1A, 1B to 3A. We have stage 4. What happened to stage 3B? We can infer from LAURA, and then which one do we use? And actually, I wrote an editorial that ALK is better. They have a real world study, which is important, but I will use lorlatinib in that case too. The principle is there. You have an adjuvant because we know it's going to work in exon 20 insertion. It's going to work in RET fusion. It's going to work in ROS1. It's going to work because it's a driver there. Sometimes we are not going to have the data because the company is not sponsoring the trial. We have to depend. I mean, in China, you can do this trial. We have enough patients. So I recommend Sai-Hong to do something like that, which is head-to-head, 2 years, 3 years, lorlatinib versus alectinib. It will be a very interesting trial and exciting trials. I think people will be very excited to see the results. But I think you should get more than 2 years. But you can do stage 2 or 3A, so increase, in a sense, a higher stage, so you get to your endpoint a little bit earlier. And I definitely will recommend a phase 3 trial, but not phase 2 that 50 patients here, 30 some patients there. You all get activity, response rate 50 to 70%. We really cannot interpret the data. I want a head-to-head trial, lorlatinib versus alectinib, 2 to 3 years of adjuvant. Let's go.
Thank you very much. So I have another question. So regarding the adjuvant therapy, so you think maybe 1 year is enough? Can we judge their prognosis of the infect using the MRD? Because Professor Wu just published a paper in the Cancer Cell to recommend the treatment holiday for the patient with EGFR mutation. Do you think we could use this idea in the patient with the ALK mutation patient?
No, I actually, for ALK, I disagree. That's why I argue with the CML. The detection method is not that strong, so everybody who had surgery should have MRD because you really should not be able to detect anything. All surgeons will say that it's. I think the cell are just hidden there. So if you use 2 years, you're gonna relapse, and I'm not sure Roche is going to present the data because then they will tell them 2 years is not enough. We know 3 years is not enough in adjuvant osimertinib. We already know the relapse started after 3 years, and that's why there's a 5-year single-arm study of adjuvant osimertinib. So the longer the better. It is just like endocrine therapy in breast cancer. 10 years better than 5 years, and 20 years is better than 5 years. Another way to do this is instead of going head to head, after 2 years of alectinib, which is now, or ensartinib, you randomize patients to lorlatinib versus placebo. Then we will know whether 2 years is enough, whether 5 years is enough. That's another. It's actually cheaper for Pfizer to do that because they only have to supply placebo. You can do 2-to-1 randomization. At this point, the standard of care is 2 years of adjuvant ALK TKI based on ALINA and Elevate. But let's say you have 3 years of lorlatinib versus placebo. That's another Sai-Hong trial. That is actually very manageable. 2-to-1 randomization, 2 patients got lorlatinib, 1 patient got placebo. You do regular MRI scans, you will pick up progression very quickly. That's my prediction. And then you will realize that 5 years of adjuvant TKI is better than 2 years of adjuvant TKI. I think that is a very easily doable, and you can do Sai-Hong. I'm not personally. I don't think chemo TKI free is the way because CML you can see they already relapsed. ALK, we don't have. Once you relapse, the CML, you can go back and relapse and repress it because from the bone marrow, from the cells. But ALK in the brain and all that, we are not at this stage that I'm comfortable to say, because the CML data, the only disease that have treatment-free remission is from CML, and their data is still scary in a sense. They all relapse within 50% relapse within 3 months. The good thing about CML is you can add ALK TKI and repress it. So I am not in the camp that you can stop the drug, unfortunately. But it's also osimertinib. It tells you 3 years is not enough, especially state. You can pick 2 to 3 ADCs and run this trial after 2 years of lorlatinib and Satinib, randomized 3 years of lorlatinib versus placebo. You don't have to have Pfizer to do that because that should be pretty. I mean, you can get the results very quickly, and you only have to supply placebo, which is cheaper than head-to-head with lorlatinib.
Okay, thank you very much.